Hi, Assalamu alaikum. I'm with you guys, Nawab Salah, a medical student, and today we're going to begin this series with looking at the series of conditions in ophthalmology and revising with one another. So the way this is going to work is we're going to look at cases. Most of them are cases we're going to read together, and we're going to discuss, or you should really answer to yourself the question what this might be, because we're going to discuss the diagnosis, differential diagnosis, the investigation and the treatment. I might go into detail in some condition more than the other, depending. The series is just to give a general idea. It will not be complete, but I'll have to give a general idea as much as possible as I want for the most important things that we would need to know. So before we start, we need to know about the two chief complaints that any of us, even if we're not going to go into ophthalmology, two complaints related to the eye we need to know. One of them is complaints of vision, and the other is red eyes. Let's start with red eyes. Patient may come to the clinic complaining of red eyes, and at this point you need to know the differential diagnosis. So try to memorize them for the starters, and you will approach as we go through cases. You'll get an idea what red eyes is. Of course, red eyes refer to hyperemia of the conjunctiva, or hyperemia in the sclera, or it could be related to the uvea or the lid, whatever. Redness is associated with inflammation. So really, when we look at differential diagnosis such as angle closure glaucoma, this is a very severe ocular emergency we'll see later on, presented with red eyes. Another one are anatomical structures such as conjunctiva. The most common cause of red eyes we should always think of is actually conjunctivitis. Conjunctivitis has many types. It could be bacterial, could be viral, could be chlamydial, which is bacterial, could be allergic, or it could be a case of chemical reaction sprayed on your eye. Say a base, or you have an alkaline chemical sprayed in your eyes. In this case, by the way, you don't go to the clinic. If someone with you, let's say a doctor, he has to clean your water or irrigate your eye with tap water for 15 minutes at least before coming to the clinic. Because by the way, if there's chemical injury to your eye, then that eye can easily penetrate through the ocular surface, your eye surface, and it's irreversible. So typically in a chemical injury, you wear eyeglasses if you can. If you get sprayed, you need to irrigate your eye with tap water for 15 minutes before going to the clinic. So that's important. That also involves the conjunctiva and causes red eyes as well. Other ones can be cornea, like keratitis, inflammation of the cornea, could be infectious or non-infectious. Uveitis for the uvea, and this is a very severe case that we'll see later on, in which a case of uveitis can be a patient who comes to you with sudden loss of vision, with painful eye, red eyes, tearing, lacrimation from his ear, lacrimation from his eyes, as well as the fact he has photophobia, his squints away, he closes his eyes from the light, and his pupil is narrow. That's going to be important when you differentiate uveitis from glaucoma. Glaucoma actually will have a mid-dilated fixed pupil when we see later on, but in uveitis, it's a narrow pupil. So that's obviously an ocular emergency, okay? Besides that, scleritis, inflammation of the sclera associated with rheumatoid arthritis, give topical steroids, Lid could be sty diseases, eyelid infections, could be sty, could be infected chalazion, could be complicated blepharitis, anything really, okay? This is for the red eyes in general, so we just want to have a brief idea. The other one we need to know are the signs of the visual loss. And regarding these signs of vision, typically in cases, they will not say loss of vision. They'll say the person has decrease in their visual acuity, meaning that this patient has, instead of a 6/6, or let's say a 20/20, this is the normal, the patient may have in his right eye 6/24. This basically means that what you see at 6 meters is what a patient sees at 24 meters. Basically, instead of seeing the big letter, let's say we have a chart, a Snellen chart, we have the big E letter. Instead of seeing it as you normally could, basically from afar, you have to come closer. Let's say at 6 meters, you have 6/60. That means you see the font letter or the letter at font number size number 60 at 6 meters. That's very, very bad. So 6/60 means you have a deficient visual acuity. But 6/6, that's good. So the number 6 here refers to the meter. The other 6, the second one, refers to the size of the letter, the font size of the letter in the chart. What you're able to see at which meter. The normal or the perfectly acceptable is 6/6 or 20/20. So typically when we say vision loss is lost, acute or chronic, few days or over the past few weeks, they tend to say the visual acuity in one eye is decreased, 6/24 مثلا. Right eye, they say it OD in prescription. Left eye, they say OS. If they say OU, then really, these are really words Latini. OU means both eyes, okay? So if you see in prescription ODOS, that's what they mean, okay? And typically these visual acuity, they could be related to refractory errors. Maybe this patient is myopic. Maybe this patient is hypermetropic. Myopic, basically patients like me. I have to wear a concave lens to be able to see distant vision. A near vision is fine, but in hypermetropia patients, the opposite. Near vision is blurry, they have a poor accommodation, and basically distant vision is fine. Presbyopia, if you hear of a case of presbyopia, it's the same as hypermetropia, but it's considered normal. When we get 40 to 50 age group, all of us will need reading glasses, because by that age the lens will get weaker, our accommodation reflex will become even lesser and lesser in its power, and eventually we'll need reading glasses. So refractive error can be related to loss of visual acuity, and we'll see it especially in chronic visual loss. So if you look at acute visual loss, we divide it also into pain or painless. Is it associated with eye pain, or is it associated with no eye pain? Now, in this case, with the pain, we want to know some of the symptoms, we want to know some of the conditions, such as angle closure glaucoma, again, uveitis, again, endophthalmitis. This is a complication of post-cataract surgery. When people do surgery for cataract, they might come 1 week later complaining of sudden loss of vision with severe eye pain and red eyes, مثلا, and tearing. And then you notice that this patient has endophthalmitis, which is infection inside the eye by bacteria due to contamination during surgery. And this is very, very bad, because this patient might come after cataract surgery 1 week saying, oh, my vision just deteriorated and I have all this pain. That is very bad. Of course, the only treatment for endophthalmitis, by the way, you have to inject an antibiotic inside the eye. Intravitreal injection. Inject inside the vitreous humor of the eyeball. Okay? You have endophthalmitis. Next is keratitis, again, inflammation of the cornea. Optic neuritis, you'll see in multiple sclerosis. Scleritis, we mentioned it. Orbital cellulitis is an infection behind the orbital septum caused by Staphylococcus aureus. Really, this is a complication of sinusitis. If you have an untreated rhinosinusitis by bacteria like staph, it will go to the eyeball and cause orbital cellulitis. And this is also an ocular emergency. A lot of these are ocular emergencies. These are things that you have to treat immediately, okay? Then you go to the painless type. You have sudden loss of vision, but it's painless. Then at that point, you have to think of vitreous hemorrhage. Then at that point, you have to think of retinal detachment. You have to think of retinal vascular diseases, central retinal artery occlusion or central retinal vein occlusion. You think of occlusion in the artery of the retina or occlusion in the vein of the retina, or detachment of the retina, or hemorrhage within the vitreous humor of the retina. These are causes that can cause sudden loss of vision but painless. And take it as a rule, any disease in the retina or the lens will be painless. There's no pain receptors. But outside, the cornea, the conjunctiva and all that, no, there will be pain, okay? Besides that, there'll also be a differential diagnosis, and we'll look at all these in details, especially vitreous hemorrhage. This is a complication you'll see in diabetic retinopathy as well. And also from the same condition here, central retinal vein occlusion. You'll see that this condition, it's really a sign. It comes as a result of neovascularization, abnormal blood vessels being ruptured, and we'll see what that means in future videos. But we'll go to the differential diagnosis here. Anterior ischemic optic neuropathy, divided into arthritic and non-arthritic. Basically, one of the ways the optic nerve can be damaged or affected inside your eyeball right here, like this fundoscopic exam, is by ischemia. You can have ischemia associated with ischemia related to an artery, or it's not related to an artery at all. No inflammation, no nothing, but there's hypoperfusion. The more common, unfortunately, is the non-arthritic, because you'll see the complaint of sudden loss of vision, okay? But typically, you'll see nothing besides fundoscopic examination showing a swollen optic disc with a lot of blood vessels, okay? And the thing is that there's no treatment for the non-arthritic type. But for the arthritic, yes, because arthritic anterior ischemic optic neuropathy refers to GCA, giant cell arteritis, basically a very, very, very huge inflammatory condition related to the superficial temporalis artery, where you have high levels of ESR, the C-reactive protein. Of course, this high level inflammation can obliterate the lumen of the artery supplying your optic nerve and can lead to ischemia. And also, this occurs in elderly patients, like 70 to 80 year age group, in which these elderly patients, they might come with sudden loss of vision painlessly, and they may come with pain not in their eyeball but in their jaw. They might have jaw claudication, scalp tenderness, they might have a headache, severe headache, weight loss. All of these are systemic symptoms along with fever that might come with giant cell arteritis. And luckily, there is treatment for this where you give the patient steroids. All right, so that's a brief information about this condition as well. Besides the acute vision loss, we go to the chronic vision loss. The chronic vision loss, when we look at the painless type, and in the painless, we have some cases, like we mentioned, refractory error that can occur with long period of time. Chronic glaucoma, again, if you see, by the way, if you see a case of glaucoma, if it's chronic, you'll know if you can do fundoscopic examination. Because when we look at acute glaucoma case, an acute attack of glaucoma, fundoscope is almost impossible. You're not able to do it. The next one is retinitis pigmentosa. This is basically a genetic disease, and you'll see this especially in young people because this is a genetic disorder where there is retina dystrophy. There is not degeneration, no. Retinitis pigmentosa, there is dystrophy, meaning basically there is malformation of the retina, malformation of the retinal pigment epithelium. The pigment of the retina that contain the photoreceptor, the rods and cones, there is basically deformation, or basically their change in their shape. Okay, there's no degeneration, they just became abnormal, and as a result they become abnormal in the form of pigment deposition. So you look at a fundoscopic examination of someone with retinitis pigmentosa, will have gradual progressive loss of vision, and in a fundoscopic examination you'll see these black spots. There will be black spots at the periphery of the retina, and these black spots are at the periphery of the retina affecting vision, specifically night vision. So that's why someone with retinitis pigmentosa is a young male patient coming with progressive loss of vision as well as night blindness, because it will affect the periphery of the retina. But if it affects the central, that will be day vision, especially when you look at cataract. Some cataract include a opacification of the lens at the center. They call it nuclear cataract, and that can affect the day vision. The day vision, your daylight vision, can be affected if it's at the center, if there's affection in the center. And in the case of retinitis pigmentosa, with really being the periphery of the retina being affected, it will be the night vision. So you'll have night blindness. And it's not exclusive to retinitis pigmentosa. You'll see this in vitamin A deficiency. You'll see this in other conditions as well, so it's not exclusive per se. So that's one example of retinitis pigmentosa, and there's no treatment. You'll just see in fundoscopic examination pigment deposition, black colored pigment deposition. Optic disc may be waxy colored or atrophic, indicating it's not working as much, and maybe narrowing for these arterioles. Some findings of retinitis pigmentosa regardless. The next one is diabetic retinopathy. DR is diabetic retinopathy. It could be proliferative or non-proliferative. We'll see it in other cases. And besides that, the last one we want to really discuss in details is the one that none other than macular degeneration. This is related to elderly folks. First of all, macular degeneration occurs in elderly people, 60, 70 age group. You see, with aging, there can be oxidative damage to the macula. The macula basically meaning the center, here, this center right here. Let's say this is the optic disc. Next to it is the macula. This point right here is the fovea. So there's degeneration of the macula, and there's degeneration of the macula. This represents the central part of your retina. So degeneration means loss of central vision. That means you lose daylight vision. That means you lose vision in general, and it can be permanent. Okay? Progressive loss of vision. Nothing else besides that. And the reason this occurs is with aging. There's oxidative damage to the retina. Here there is degeneration. There's no dystrophy. There is degeneration to the actual macula. So let's assume this is the retina or the macula. We did a zoom in. It consists of RPE, retinal pigment epithelium, as well as a basement membrane, let's say, and this basement membrane separates it from the choroid. The choroid represents the vascular supply of the retina. You see, with aging, there can be degeneration of the retinal pigment epithelium that contain the rods and the cones, the photoreceptors. So there can be deposits of fats and proteins here, known as what? Drusen. These drusins are basically garbage that accumulate here in the retinal pigment epithelium and the photoreceptors and cause atrophy. And we call this as the dry type macular degeneration, where if you look at fundoscope, you'll see basically these spots, these yellowish spots, these are your drusen. And these drusins represent that there is breakdown of the macula and you're starting to permanently lose your vision in that area. The problem with drusen is eventually the dry type here might progress to wet type, where basically eventually over time there can be new vascularization coming from the choroid. Basically with necrosis and inflammation and atrophic changes, the choroid representing your vascular supply, it will be stimulated by production of vascular endothelial growth factors. Growth factors that stimulate growth of new blood vessels. But is this a good thing? No. These new blood vessels are fragile and they're liable to rupture. So new vascularization can eventually lead in wet type macular degeneration, hemorrhage. You might have hemorrhage in the retina, hemorrhage underneath the retina, and edema that leads to macular edema, and eventually can lead to permanent loss of vision. Okay, so that's something to keep in mind as well. And there's no treatment for macular degeneration except in the wet type. In the wet type, you can give here intravitreal injection of anti-vascular endothelial growth factor antibodies. You can give it to stop the new abnormal blood vessel growth, but nothing more. Okay. Besides that, the only way to diagnose for macular degeneration or do a follow-up is give the elderly patient a chart. This chart is known as Amsler grid. All right, Amsler grid. This chart right here. This Amsler grid, basically, patient may come with a specific sign in macular degeneration with metamorphopsia. And metamorphopsia basically means instead of seeing one vertical line, they may see the line inverted. They sound like the line, the vertical line being folded upon itself like a paper. So if you look at this Amsler grid chart like this, and they cover one of their eyes, and they concentrate in this vertical line, and they see this folding of the vertical line, then this means they have metamorphopsia, and there's progression of this disease. So he has to come to the eye doctor to see and do a checkup, okay? So that's one way to specifically diagnose for macular degeneration. And that's pretty much it. Yeah, overall, as much as some conditions in detail, some are not, as are in future videos, the idea is to memorize and get an idea of the chief complaint that might occur: vision loss and red eyes. Okay? Thank you.